Well, when we talk to decision makers who are trying to make decisions about what we can do about childhood obesity, that could be a mayor or people that run organizations like the YMCA of the USA, they generally want to know, well, what's feasible, an intervention program policy, how effective is it, and what does it cost? No big surprises. We're, of course, interested in this cost effectiveness plane here. I tend to think of the U.S. healthcare system as being kind of the poster child for higher cost, worse outcomes. But we're really interested in that lower corner there, the lower cost, better outcomes, policy and programmatic interventions in public health. And that's what we're going to talk about a bit here today. Well, clearly we can't afford to do everything, all the childhood obesity interventions we'd like, so why not begin with those producing the biggest bang for the buck? Unfortunately, we don't have the information right now to help us make those choices, so that's what our project has been about. The Choices Project, to try and make some of these estimates. I'll talk about all of our colleagues in just a minute, but it's a nice collaborative effort across universities, folks here at Harvard, Columbia University, the Australian universities, Deakin and Queensland. Our goal in this project is really to generate cost-effectiveness estimates for 40 of the most relevant childhood obesity interventions in the United States, to engage policymakers and the general public in this issue and provide guidance so the most cost-effective interventions are identified and become a focus of discussion and action. Here's our organizational structure. I don't know if you can see the details. I tend to head the modeling team of this, which is a great group, including Claire Wong, who's now at Columbia, used to be here, Stephen Resch, Michael Long, Zach Ward, Milt, and others from Queensland and Deakin University. On the intervention side, Angie Craddock runs our intervention team to develop logic models of the interventions. Andrea Pepito heads our systematic review team to try and review evidence, doing systematic reviews and meta-analyses. Kelly Blondin, our costing team. And then we have a lot of support staff. We have team leads for each of our interventions that we're studying, and a lot of research assistants. And Katie Giles tends to hold us all together. She's our manager. It's a big team, and I just want to acknowledge all of their work. What we've done for each of our intervention areas is develop a logic model of the intervention, and then the intervention implementation, the cost of the intervention, and then we model out short-term outcomes over the first couple years, and then 10-year outcomes. And we look at things like DALYs and healthcare costs. A big issue around childhood interventions is children generally don't die or end up with obesity-related diseases. So the only cost offsets we generally have here are things like healthcare costs. Children who are obese incur greater healthcare costs, and of course adults incur much greater healthcare costs than children who are not obese. So that's the one area where you can get some healthcare cost. Just as Milt was introducing things, I was thinking back to those working groups that Howard Hyatt put together a long time ago around cost, risk, benefits of surgery, and I remember one of the surgeons then, John Bunker, convincing me that childhood interventions, kind of forget about it. You'll never show cost effectiveness because kids just don't get you any cost offsets for quite a while. And that has been a struggle with childhood interventions. So we'll come back to that a little later. What we developed then is a computer model to simulate the national history and interventions in the US population over a 10-year time horizon. We use Monte Carlo methods to accommodate uncertainty in model parameters regarding participation, effect size, and cost, and we use scenario analyses to explore alternative causal pathways. So clearly in this talk, I'm not going to talk a lot about the details of our models, but you can certainly ask questions. We spent a lot of time on looking at levels of evidence. In all of the models I'm going to talk about today, we've used randomized trials for the primary behavioral pathway of that intervention. In addition to the issues I'm going to talk about today, we've also been concerned with issues of equity and impact on disparities, the acceptability to stakeholders, the feasibility of the interventions, their sustainability, side effects, and effects on social and policy norms. I won't talk about any of these issues, but you can raise questions about them because we have plenty of other things to talk about. I'm going to talk about 4 of our pilot interventions out of these 40. The first is a sugar-sweetened beverage excise tax. That's a penny per ounce tax that will appear in the cost. And it's been a discussion point in the United States. Michael Long headed up that paper. A state policy requiring minimum levels of moderate to vigorous physical activity during elementary school physical education classes is another intervention. There's a nice intervention that produces that kind of a change. And Jessica Barrett is the lead author on that. A third intervention is eliminating the tax subsidy of food and beverage television advertising directed at children and adolescents. This one is interesting. I'm sure all of you know that every penny that McDonald's or Coca-Cola or Pepsi spends on advertising junk foods and beverages to kids is a tax deduction, right? Well, maybe you didn't know that, but I don't know if somebody could get me some water. I think I'm experiencing the spring allergy thing. You know. So this intervention just eliminates that tax deduction. And finally, the fourth intervention is the is an evaluation. Great, thanks. Actually, one of our interventions was about water, too. It's really inexpensive, but most public schools in Boston don't have a working drinking fountain. So let's look at some of the evidence here. When we look at the short-term outcomes for these interventions, one interesting difference is just the reach of these interventions. Sugar-sweetened beverage excise tax will hit just about everybody in the population. And early care and education policy change, for example, in preschools, will hit the relatively small part of the population. So you have some big differences here. But there are big differences in the cost per year of these interventions. The least expensive one is the television advertising change because it's just a change in tax policy. The most expensive is the active PE intervention at $55 million a year because it involves training a lot of teachers. There are differences in the per person BMI unit reduction associated with these interventions, and these estimates are based on randomized trials. But really the biggest differences are when you move to the cost per unit BMI reduction. And I'll spend a minute talking about this. I'm guessing that most of you know your BMI. If you don't, you probably should. Just check it out. And maybe some of you have been interested in dropping your BMI, let's say by 1 unit. How many of you would spend 8 cents to drop your BMI 1 unit? I don't know, $2.61. How about $181? Jeffrey, yeah, okay, you'll vote for that. Do I hear 300? Well, we really don't have a good framework for thinking about how expensive that is, but I have been involved in some studies where we've calculated this from a treatment perspective. The High Five project that Elsie Tavares ran was a randomized trial and to treat overweight and obese children. That cost about $1,000 per BMI unit change. There are nice systematic reviews, meta-analyses of bariatric surgery for children and adolescents. And our estimates here indicate this cost about $2,100 per BMI unit change. So this gives you some sense of the comparative effectiveness of a couple of approaches to both more primary prevention and then treatment later on. When we look at 10-year outcomes, here we start to get some cost offsets. because if we lower obesity rates, we're going to have lower healthcare costs. For the sugar-sweetened beverage excise tax, we get some big savings over 10 years. It's about $15.9 billion. The probability of a net saving here is very high. The TV advertising change policy is about $900 million over that period of time, savings. The early care and education policy is about even, and the probability of a net saving there is about 73%. So 3 of these really have a pretty good probability of saving costs over the 10 years. And the sugar-sweetened beverage excise tax, because it will affect adults who are at risk for a whole variety of BMI and obesity-related morbidity and mortality, will save 170,000 disability-adjusted life years over that period of time. And again, we didn't calculate these kind of outcomes for the other 3 interventions because, well, they're really not there, because you only get those kind of outcomes after about 30, 40 years of life. There's an additional benefit to 2 of these interventions that's actually big, and it's worth mentioning, and that is the sugar-sweetened beverage excise tax will bring in about $12.4 billion a year in tax revenue. That could be used for a range of things. Gee, you could pay for the active PE intervention pretty easily. You could also deal with other equity issues if you're worried about the regressive nature of a sugar-sweetened beverage excise tax. And the TV advertising change, we estimate, would bring in about $356 million a year. So these are 4 interventions. Cost per BMI unit reduction of these 4 seem to be low relative to typical clinical interventions to treat obesity that we already pay for. All 4 would likely produce broad-reaching impact at modest cost in the short term, with 3 being cost-saving within 10 years. And there are limitations to all of these analyses, of course. These are modeled studies. We have to make assumptions about our estimates, and I think we have really good evidence for all of them. We've probably underestimated some effects. We assume effects only via BMI here and don't, for example, get the direct effects of a sugar-sweetened beverage excise tax on diabetes incidence independent of BMI. And we know that that path is there. There are independent effects of physical activity. But that's the first estimates we have off our project. So why don't we open it up to discussion? Thank you.
So we have about 7 or 8 minutes available for discussion. Anyone like to start? Oh, by the way, if you have a question or comment, just step up, please, to the microphone in the middle aisle. Yes, please.
Thank you very much for a very nice presentation. Yeah. I was wondering if you could a little bit more elaborate on the cost component of your intervention. What type of cost included in your analysis?
Sure. Which intervention do you want?
Taxation, specifically.
The sugar-sweetened beverage tax?
Yes.
Yeah. Actually, Michael Long's over here. Why don't you stand up, Michael, and tell him all the details of the of the intervention. Michael, it's been a lot of time.
The costs are based on reports from 2 states that already implemented excise taxes on sugar-sweetened beverages. And one reason that the costs are so low is that an excise tax is applied only to bottlers. So there are very few locations where a revenue agent would need to do auditing and set up a taxation system. So the costs are, in general, auditing costs and maintaining a new tax system, as well as cost of complying with the new taxes on the bottler side. So we assume equivalent time costs of compliance. One thing that isn't included that's very important is the actual cost of paying the tax, which is a transfer payment. So the revenue is not incorporated into the cost, but it does generate revenue. So pretty low cost intervention. There are only a few bottlers per state in this country.
Sorry.
Go ahead. Yeah, I mean, this is one of those interventions that once you do the analyses, you go, this is really a no-brainer, and yet you see it appearing nowhere in the United States. And I think it's just a question of time. Actually, we were bummed out that in Massachusetts, where they couldn't even get rid of the fact that sugar-sweetened beverages are given a tax break here. That was in the last legislative session, but it was not really pushed by the administration. It didn't happen. But
Professor Hemingway.
I just want to mention that in Massachusetts and nationally and in California, we found cross-sectionally that there's an incredibly strong dose-response relationship between soft drink consumption and all sorts of violence, all sorts of aggressive behavior, and also depressive behavior. And we're not positive if it's a cause-effect, but we find it wherever we look among 5-year-olds, among adolescents, holding as many things as we can constantly.
thank you, David.
Hi, I have a question both about the extremely short-term benefits and costs and the longer-term benefits and costs.
Mhm.
So in the short term, what evidence is there, what do you know about the immediate welfare effects of being obese on the welfare of children? And are you counting that in some way? And then for the longer-term cost savings, do you have any sense of whether or not interventions that reduce obesity in children today, if we think about the savings to society, the cost savings to society, and also the welfare benefits to people 50 years from now, how do you think about valuing those? What kind of a discount rate would you use? How sensitive is the result to kind of a reasonable range of discount rates that one might use?
Mm-hmm. Sure, but I think I have all of them in my head. The first question about the short-term effects on, I think, children's welfare, I think is a really good question. I've spent a good part of my career very interested in those kind of outcomes. I tend to think that it does affect children in a range of ways. I actually don't trust a lot of the estimates I'm getting about effects on let's say the quality of children's lives, because I think they're bound up with estimates of stigma and discrimination. There's a lot of discrimination against children who are obese and overweight. If you look at how obese and overweight children perform in school, for example, you really don't see effects of obesity on their performance in that way. So it's a bit of a complex issue. And we're continually looking at that and are very interested in the use of, for example, QALYs to get more shorter-term effects. Being a demographer, I've been interested in long-term projections for a long time, and I know how difficult they are. There is tracking of obesity from childhood into adulthood. The strongest tracking occurs from, of course, adolescence into adulthood and later adulthood. And we're very interested in modeling out that process, but it's tough to predict the future. And one of the reasons we went with a 10-year time frame and not a 40 or 50 or lifetime time frame is because we don't feel very confident about predicting that future. I don't know if that answered your question, but I have a number of cost-effectiveness studies that have been done in the childhood area have taken this lifetime approach. Let's assume we have an effect for the rest of the life of the child.
So let me just follow up on that, if I may. Is there no evidence then that obesity during childhood predicts obesity during adulthood?
Yes, well, there's evidence. The correlation of, let's say, early childhood obesity and, let's say, age 25 obesity is something like 0.15. The correlation of adolescent obesity and age 25 obesity is much higher, 0.5, 0.65, something like that. So when kids are small, well, there's just a lot of variability in how they grow and develop. And then as they become adolescents, it really tends to track into adulthood. So yes, well, there is predictability, but in early childhood, it's not that predictive.
Thanks. Jim?
Hi.
Teddy.
This is kind of not your main point, but I was confused. You were showing the tax revenue as a benefit, and then your colleague said paying the tax is not a cost. Usually we think of, from the social perspective, the tax as a transfer. You could count it as a benefit to some, but you need to also count it as a cost to the people paying it.
Mm-hmm. So you're probably thinking of my slide here where I said an additional benefit. Yeah, I probably shouldn't have used the word benefit in this audience. For the general population, they go, great, give us the money, we'll spend it. Yes, thanks
But
for,
it is paid by somebody.
sure.
That ought to count in your calculus too, right?
Yeah, so, I mean, maybe you can tell me what I should have titled this, or, all right, it's a, or did you want me to comment on it, of what I think about it? Or-
Well,
I mean, I see it as something that, I think we're crazy not to tax sugar-sweetened beverages. I think we're crazy not to have a $1 a gallon gas tax for all of the things that we can do with that revenue and of the other goods that we'll produce. But I'm not sure I'm framing it the way that some folks in the audience here would like
But
yourself.
that might be all right, but couldn't we extend that argument to we should raise the sales tax on other things? We should raise the income tax because there are many good things we could do with the revenue?
Yeah, I think it's a good idea to raise the income tax on high-income earners. But
I think we're getting a little bit outside the scope of this symposium. We have time for one more question. Josh?
Thanks, Steve, for the presentation. I wanted to follow up on the cost question, particularly about policy changes like taxation ones. It seems clear and convincing that once you can get that policy changed, it seems to provide lots of benefits at a reasonable cost. But the hard part seems to be to actually change the climate, the policy climate, to actually get new taxes put in. And so I'm wondering if you've got ideas about what are the specific activities that you can do to shift the policy climate in order to make new taxes more palatable. And you know, in principle, those activities themselves should have costs that are included, right? So you sort of start from the point when there's a new tax. But I think thinking of this as a strategy for addressing childhood obesity, you might want to start a little bit earlier and say, what can we do to actually get this policy enacted? So I'm wondering if you could comment on what are the activities that we can imagine that could actually bring the discourse and the policy climate around to where a tax is possible, and to start to play out what would be the costs of actually operationalizing these actions as well.
Mm-hmm. That's really a good question, Josh. I tend to think that our whole project is focused on starting to provide a basis for this. If you can show that, well, among these 40 different things that people have been talking about, one of these tax interventions seems to be the one thing that's going to help drive a lot of stuff best and be most cost effective. Well, that will help drive the dialogue. And that dialogue hasn't been happening. I've been working in the childhood obesity area for more than 30 years now, and you have people talking about, we have all these interventions, we could do all these different things, and yet there's no ranking of them, of where should we focus our attention. Attention is starting to get focused in that area, and I think as soon as one or two states start to pass that tax and start to see the benefits, we're going to see a real shift. It's like one of those tipping point things, you know, it'll change dramatically. Think of the first tobacco taxes. I remember before people had tobacco taxes, people said, oh, you'll never get those in, and then everything changed. So I think that's part of the process. But the other part of the question, what would be a price tag on this? I have a grant proposal for actually doing just what you're talking about. But we do have a bit of a price tag on that.
Well, I'd like to thank Steve for a very interesting